Good evening, everyone, and welcome to The Truth About Breast Cancer, a Survivor's Perspective, a virtual discussion hosted by Tallahassee Memorial Healthcare, your hospital for life. I am Alicia Hill, and I'll be your moderator today. I am the Director of Communications for the Tallahassee Police Department. Before taking on this role, I served as an anchor and reporter at WCTV right here in Tallahassee. On a personal note, I have two grandmothers that have been diagnosed with breast cancer. And as a journalist, I was entrusted to tell a number of stories of women and their families sharing the impact breast cancer had on them. It is an honor to moderate tonight's discussion again this year, and I hope that it makes everyone in our community more willing to ask questions, seek help, and utilize the amazing resources right here in our backyard. I'm sure we can all learn something from each other today, and I'm excited to kick off what will be a wonderful conversation. We are joined this evening by an incredible panel of clinical leaders here at TMH, as well as a breast cancer survivor who experienced life-saving cancer care at Tallahassee Memorial. Whether a surgeon, a nurse, or a survivor, everyone with us today brings a unique perspective when it comes to breast cancer. So I'll start by introducing our panelists for this evening. We have Betsy Brown, local attorney, mother, breast cancer survivor, and advocate. Dr. Shelby Blank, medical director of the Walker Breast Program and general surgeon at TMH. Dr. Jeannine Silberman, medical oncologist at TMH and psychiatrist. Dr. Alfredo Paredes, plastic surgeon at Tallahassee Plastic Surgery Clinic and TMH. Yusef Syed, MD, radiation oncologist at TMH. And Amy Anderson, RN, breast cancer nurse navigator at TMH. Again, thank you all for joining us. Many of our viewers submitted questions ahead of time, so we'll be sharing those with our panelists during this discussion. And then if you have any additional questions as we go, please use the Q&A feature in Zoom to submit them. I'll be monitoring them as they come through, and our experts will answer them in real time. So at this point, I think it's time to jump right in. And when you're talking about breast cancer, I think it's important to start at the beginning in the breast cancer diagnosis. So Betsy, will you please kick us off by sharing how you discovered a lump and ultimately received your breast cancer diagnosis?
Sure. So my story began on September 23rd, 2016. That was the date of my diagnosis. A couple weeks prior to that, I was in the shower and not even performing really what you'd call a self breast exam, but my hand happened to notice something on my right breast that didn't feel right. And as I broke into a cold sweat, I started feeling it more, and then I knew it didn't feel right. And so the first thing I did was call my doctor. First thing I did was freak out. And then I called my doctor, my OBGYN, just to get some guidance about what I should do next. And his advice, which was very good advice, was you need to get this battery of tests. Go to TMH, get a mammogram. We'll get you set up with an ultrasound as well. And if we need to go further, we will. So I did those things, and then I received inconclusive results. So then we did a biopsy, and the biopsy came back as invasive ductal carcinoma, triple negative, and stage 2. So that is how I got my diagnosis.
In the world of Zoom, it's bound to happen. It's fun being on mute, but thank you so much for sharing that. Dr. Silberman, can you now jump in and talk about the importance of detecting breast cancer early? What are some of the signs and symptoms women and even men, they're an important part of this conversation as well, that they should keep an eye out for?
Sure, absolutely. So there were several parts to your question, but I'll just start by saying the earlier that you detect breast cancer, the better off that patients are. The earlier the stage is, the more treatment options and chance for cure that most patients have. So fortunately, we're in an era where we have an amazing screening test called the mammogram. Nothing replaces the mammogram, at least currently, and that includes breast self-exams and even clinical exams in your doctor's office. Now, that doesn't mean that you shouldn't have those or do those personally, but what that means is that the way to detect, the most sensitive way to detect breast cancers early with the least amount of error is with a mammogram. So there is a lot of controversy, and I think we're going to get to this shortly. There is a lot of controversy about when to start mammograms, how often to do them, and we can talk about that shortly, because you had some other parts to your question. Many of our patients, like Betsy, develop breast lumps, and that's the first sign that something's wrong. So I think that most clinicians would not discourage patients from doing breast self-exam. That's not at all what I'm trying to say. It's just, it's not the gold standard for screening the way mammogram is. So please, by all means, do those things, but also go in for your annual mammogram. Men are affected by breast cancer. We have a number of male patients here at the Cancer Center. They detect them usually the same way that women do, by feeling a lump in the breast, much less so by mammogram, because men don't have screening mammograms unless they have a known history of breast cancer or they're high risk. Many of those men have a genetic mutation that's passed on from family to family called the BRCA2 mutation. In that case, they should start breast cancer screening, but that's a separate category. For most average risk patients, you should be having annual mammograms, and have a conversation with your doctor about when to start those, because as I mentioned, there is some controversy.
Thank you so
Sorry,
much.
it was an earful.
And so the next one is for Dr. Blank or for Dr. Silberman. We know some people will never find a lump, and you talked a little bit about this, but instead find out they have breast cancer from irregular imaging. What role do mammograms play in detecting breast cancer early?
As Dr. Silberman pointed out, there's no one perfect way to find all breast cancers, and so many people will find theirs on self-exam or notice it in the course of their life. But most, I would say, breast cancers that I see on a day-to-day basis are found happily on screening imaging. And I say happily because that often affords us the opportunity to find them at a much smaller point in time and a much earlier stage. So I think that, certainly the surveillance screening plus self-awareness plus having your doctor do an exam, when you put all those three things together, then the risk of missing something or only finding something at a much later stage goes way, way down. So I certainly think that screening program is a really, really important part of things. Almost everyone should have kind of at least some evaluation, and most recent studies kind of say that you should at least look at that at age 25. That's certainly by no means that someone needs imaging or routine, radiographic surveillance at age 25. But what that means is you need to, your doctor should be having a conversation about family history, because if you have one of those high risk genetic mutations, then that's the time that we really recommend starting that early detection. Most people in the world don't fall into that. That's more of an unusual category. And still most of the recommendations are for annual mammograms starting at age 40 for an average risk person. But it's important, again, on a case-by-case basis to have those conversations with your primary doctor.
And Dr. Blank, staying with you, are there factors that can put someone at a higher risk for breast cancer? And if so, what are they?
Certainly. I mean, I think we and Dr. Silberman can add to this. We kind of break these down into risk factors that you can change and risk factors that you can't change. You can't change that you're female, and we generally don't want to change that we're getting older. And those are two probably the biggest factors. We know the risk factors of developing breast cancer are certainly higher if you're a female and higher as we age. The things that we have some control over can be certain lifestyle choices. So a sedentary lifestyle, so having a regular regimen of exercise, keeping your weight down, obviously making kind of other healthy life choices, are important. There are some we know that are inherited. So those are the non-modifiable. So family history, risk factors. Even if you don't carry one of the genes for breast cancer, you may still have a risk by family history. Other things are, not having babies, not breastfeeding. Those are our choices, and those are not reasons to make those choices, but they're just things to keep in mind that if you've never been pregnant, if you didn't breastfeed, if you had early onset of your menstrual cycle or late menopause, those are unexposed years of exposure to estrogen, and we all know that those are things that can increase your risks. So I'll let Dr. Silberman chime in. She may have some additional things.
Well, that was a really comprehensive list. I guess one other thing I might add would be something like hormone replacement therapy, which is women are not uncommonly put on because of menopausal type symptoms. So hot flashes, mood swings, things like that. So in middle age, it's not uncommon to be put on those medicines. The key is to have a conversation with your prescribing doctor about how long you need to be on them, or is there a non-hormonal alternative that can address your symptoms? Because that does elevate your risk of developing breast cancer.
And so, Betsy, going back to you, did you have a family history of breast cancer or other risk factors associated with the disease?
No, actually, I did not. I had no family history of breast cancer, which I think kind of led me to a sense of false security in a way. And I've since learned that I have no genetic aberrations that would lead to breast cancer either. So, and listening to the risk factors that Dr. Blank was telling us about, well, I did have kids. I had 3 kids. I breastfed all of them. So, I had that going for me, but I still got cancer. So, to this day, I still don't know why it happened to me. And I may never, other than, some cells just kind of went crazy. But no family history whatsoever.
I think there's a perception, and we always get asked the question of, why this happened to me, why this happened now. And there's sort of this idea that there's something you can do or not do. And I think, every patient's a little bit different about, how their risk factors all played together and why this happened. But I would say in many, many, many cases, there's really nothing, you did all the right things, you do the healthy lifestyle and you exercise and you had kids and you don't have family history and all of those things. And yet you still get breast cancer, and you get breast cancer at a young age. And that is just, unfortunately we can make these generalizations, but sometimes it just happens when it shouldn't happen. So.
And this question is really just for anyone. Is there any, when you talk about those misconceptions in the community, and oftentimes people just thinking that their mother or their grandmother or someone they know had to have had it, is there any importance when you realize that some of those things don't happen and it still happens to you, the importance of detection and just making sure that you're still managing to have a healthy lifestyle, but also understanding that there are some things that happen? Any importance of just having those conversations within the community?
I think so. I mean, I think that as Betsy said, sometimes the thought that you don't really have a strong family history or strong identifiable risk factors do lead folks to kind of a false sense of security. And so I think having that conversation of, it is important to have screening, and it is important to be diligent about mammograms and things like that, and following up. So, and the same lifestyle choices that reduce your risk for breast cancer also reduce your risk for a lot of other things that can be risky for your health, cardiovascular disease, diabetes, all of those things. So it's you can make one life change and reap a whole lot of benefit. So, but I do think encouraging, your friends, your relatives, what have you, that just because no one in their family's ever had breast cancer, that's you still need to be rigorous about that screening.
And talking about lifestyle and habits, Dr. Paredes, can you talk about the impact tobacco use has, not only as a risk factor for breast cancer, but also the recovery process?
Sorry. In today's world, it's not just tobacco use now, it's also vaping. So we say more nicotine use. So you get nicotine from smoking, from vaping, from Nicorette patches and gum, dip, snuff, chew. So now we have to ask all those questions. So it's the daily intake of nicotine that's the danger. Nicotine itself is a known carcinogen. That means we know it can cause cancer. Its relation to breast cancer is a little trickier. It's more related to lung, kidney, bladder, but it is a known carcinogen. What we do know is that it affects wound healing significantly. So we ask patients to stop smoking immediately or stop their nicotine use immediately. It's a chemical that once it gets into your bloodstream, it can cause your blood vessels to shrink in size. We call that vasoconstriction. That means you'll get less oxygen to the tissues. And when you do breast cancer surgery, we need really robust blood supply to the skin to have it survive the operation. So a nicotine user can experience dead skin or skin necrosis after surgery. They have about an 8 times higher infection rate, and it can also infect the reconstruction that we do. So it's important to quit it as soon as you can, even if you get diagnosed, like the day you get told, because every week that goes by enhances your ability to get through surgery more safely. In terms of quitting and nicotine cessation, the Cancer Center offers connections to clinics. There's tobacco or nicotine cessation clinics that are around. Some of them do recommend like nicotine patches and gum. The problem, of course, that is you're getting nicotine into your body at the time. So unfortunately, if you have to do it quickly, it is a cold turkey sort of stop right now sort of advice. There is a medicine we can put people on called Chantix. It does help a lot of people quit a nicotine habit by working on the crave receptor in the brain. So there are lots of options out there, and the Cancer Center can get patients plugged into that to stop nicotine.
Thank you so much, Dr. Paredes. And before we dive a little bit deeper into the treatment process, I do want to remind everyone that if you have questions that you'd like answered or asked to our panelists, please be sure to use the Q&A feature here to make sure that we can get those asked. So Betsy, we know everyone's plan is different as far as care. What did the treatment plan you and your physician come up with look like?
Well, my doctor that I called immediately gave me very good advice. He sent me to TMH, which is where Dr. Blank works. So she was the general surgeon I saw, and we kind of knew each other. We have a mutual friend. So I had my friend reach out to Dr. Blank and make sure she could, see me as soon as possible. And so she got me in, and she sat me down with myself and my mom, and she just kind of walked me through everything. And it was such a great relief, because at that time, this was a little over 6 years ago, we didn't have the Walker Breast Center yet. So I didn't know. One of the first things I asked myself when I got my diagnosis was, okay, now I have this information, but what do I do next? I had no idea what the next step was. So getting in with Dr. Blank so she could kind of help guide me was very, very important. So I went to see her, and then one of my other doctors on the panel, Dr. Paredes, and the three of us together made a plan, and that plan involved bilateral mastectomies and reconstruction, and then at the same time I'm preparing for that, consultation with an oncologist, a medical oncologist at TMH, which I saw the wonderful Dr. Russell for that, and so just having these doctors kind of tell me what to do and what step to take next, and be so understanding and gentle with me, knowing that I didn't know anything. That was a crucial first step for me.
Absolutely. And Dr. Blank, we know TMH has developed the Walker Breast program, which Betsy said wasn't around when she was first diagnosed, to streamline the patient journey from diagnosis to treatment. Tell us about that experience, and what does the breast cancer treatment process look like for patients who come to TMH's Walker Breast program?
Well, I think what we've really tried to do in the intervening time, sort of from the time when Betsy was diagnosed to today, is take that process, which always had the individual parts, but kind of bring them together so that the patient's journey is as seamless, as efficient, as quick, and really to take as much of the heavy lifting off of them. As she said, when you have this diagnosis, you really, for most people, don't really know where to turn. This is all uncharted territory. And so to try to give people a framework that gives them a lot of information, but in a manageable way, and hooks them up with all of the caregivers that are going to be part of their team as quickly as possible, so they can kind of feel that comfort, and also make sure that we're looking at their specific case from as many vantage points as possible, so that Dr. Syed, Dr. Silberman are all, the pathologist, the radiologist, everyone is kind of looking and offering their best recommendations, so that from day one, we're really able to kind of chart that plan and know that we're offering sort of the best recommendation from all fronts. So that's really something that has been a key part of this, and something that I think we're proud of. We are always kind of moving the bar, and there's always more work to be done. But I think right now, patients have the opportunity to come in and really get a complete multidisciplinary plan in one visit, and really kind of kick things off without delays. And that's, I think, been a game changer for a lot of patients, particularly if they live far away or have a commute. It certainly makes a big difference. So.
Such an incredible resource to have in our community. Amy, what role do you, as the breast cancer nurse navigator, play in this process?
So as the breast cancer nurse navigator, I'm a direct patient contact source for resources, education, identification, and elimination of any barriers they may have to their care, and just overall making sure that whatever the plan is goes smoothly and there's no bumps in the road. If so, I try to step in and help eliminate those.
Perfect. Let's talk a little bit more about surgery. Dr. Blank and Dr. Paredes, many women may hear the words breast cancer and instantly think of mastectomies. Do all women diagnosed with breast cancer need to undergo surgery?
Almost everyone will have surgery as part of their plan at some point along the way. There are no always and no nevers, but that surgery is typically going to play a part. It may not be the first step. There are a lot of different regimens, and I always tell folks, it's good to get insight from people that who've had breast cancer before, but realize that your journey may be very different. Not everyone will need chemotherapy, or not the same type of chemotherapy. Not everyone will need radiation, but some people will. So part of it is kind of gleaning those things that are helpful, but realizing that your plan may be a little bit different than your mom's, your friends, the person who's kind of going through the process with you. Surgery from an initial standpoint typically falls into one of two categories. One is mastectomy, with or without reconstructive options. The other is lumpectomy, or what we call breast conserving therapy, which is keeping the breast but removing the cancer with good margins. That's typically where our colleagues like Dr. Syed comes in, where they offer radiation. Radiation as an adjunct to lumpectomy really gives us great results in many cases. So again, there are a lot of factors that go into recommendations for which surgery might work best. Size of tumor, that family history comes into play, and patient preference. So a lot of times patients really have all options open to them, and really they can kind of decide what they feel comfortable with. And there are a lot of reconstructive options. Even with lumpectomy, we sometimes involve Dr. Paredes and our plastic surgery colleagues to give patients the best cosmetic outcome, whether they're having mastectomy or lumpectomy.
And aside from surgery, what are some other common treatments that are used to treat breast cancer?
So I'll kind of kick that to Dr. Silberman and Dr. Syed. They both act, they're sort of three prongs to the treatment for breast cancer, surgery being one. Medical therapy, and that can be chemotherapy, as many people think of chemotherapy, but also options for endocrine therapy, and then radiation. So I'll let them kind of talk about their sort of their role and their specialty.
Dr. Silberman, do you want to start with some discussion of systemic therapies?
Sure, absolutely. So the systemic therapies, or the therapies that treat your entire body, would be something like chemotherapy, and endocrine therapy, which is anti-estrogen therapy. So both of those modalities are not for everyone. It really depends on the type of cancer you have. What is your receptor status in terms of estrogen, progesterone, and HER2 receptors? What's the stage of your cancer? How advanced is it? All those things are taken into consideration when determining who needs which therapy. Whereas surgery and radiation, which Dr. Syed will talk about now, are local therapies specifically targeted to the area of the cancer.
Yeah, so the first decision that a patient makes with our surgeon is what type of surgery to get up front. And as Dr. Blank mentioned, there's the option of lumpectomy versus mastectomy, or removal of the whole breast. And what we found after many studies and years of research is that by combining radiation therapy with lumpectomy, we achieve equivalent outcomes as compared with mastectomy. So women have the option to keep their breast and undergo a local excision combined with radiation afterwards, and essentially see the same health outcomes as removing the breast entirely. Radiation typically comes at the end after any sort of systemic therapy, should that be indicated. And there are many different radiation regimens. I can touch on those a little bit later, but I'll leave it with that for now.
Thank you so much. Dr. Paredes, can you talk about reconstructive surgery? Are all patients who undergo mastectomies candidates for reconstruction?
I find that most patients I see end up being a candidate. Whether they actually want to have reconstruction or not is a different question. The timing of it also can vary. We will meet a patient, go over their medical history, and determine, are they able to handle the extra surgery that we're going to do in addition to what Dr. Blank has to do with the lumpectomy or the mastectomy. So certain medical histories, like let's say really uncontrolled diabetes, or they're a chronic nicotine user, if you had a heart attack 2 months ago, these are things that might want us to delay the reconstruction. So we'll divide reconstruction to both immediate and delayed. Immediate means that I meet the patient, we schedule something with Dr. Blank, and we go ahead and start a process. That process takes 2 or 3 surgeries. Many patients are disappointed to find out they're not going to wake up with their reconstruction totally completed, after their mastectomy on that same day. It is a process, and that's the first shock that a lot of patients get, that we'll be together for about 8 to 12 months, sometimes even longer with patients, depending upon if they end up getting chemotherapy and radiation. That can actually drag it out a little bit longer. But at the end of that journey, we reach a point where we try to reconstruct a mound that women feel comfortable with, and men, in their clothing. The types of reconstruction vary, obviously, and it depends on, a patient's choosing in many cases. Sometimes the cancer will make us want to delay things. So if it's an advanced cancer, or we're still not sure about some things about lymph node status, we'll go ahead and get the cancer therapy over with and maybe get through systemic therapy and radiation therapy, and then come back later and do reconstruction. Some patients, quite frankly, when they meet us, they've met so many doctors that by the time they meet us, they're a bit overwhelmed by the amount of information they're getting. And I've had some patients who just feel that reconstruction is just not the best timing. It's just too much to think about. They just want to concentrate on their cancer, and that's perfectly fine. And so we recommend they just get through their cancer. And the nice thing is we can get to reconstruction months to years later. There is no time clock, and that's a common misunderstanding, that we have to get to it within the year or insurance won't pay for it. That's really not true at all. You can come back years later and still get reconstruction. So that's the point of meeting with your plastic surgeon and deciding the timing and the type of reconstruction.
And Betsy, you received reconstructive surgery. What would you tell another patient who's considering reconstructive surgery following a mastectomy or lumpectomy?
Well, the first thing I would tell them is it's not a boob job. It's not the same thing at all. As Dr. Paredes just explained, I did have chemotherapy as part of my regimen for 5 months. So I started the process immediately, and then we put everything on hold for a while. And there were lots of reasons for that. But then when I was done with chemotherapy, I could come back to the process and we could keep going. But even having said that, it was multiple surgeries, and it was about a year and a half that that I was finally done with my last one. And not only that, but you go through all kinds of interesting things like tattoos, you know, to look like your body parts, and the fact that it's not quite the same, and you are going to have some scarring. So it's a very personal choice that every woman has to make. But I have a lot of friends who've decided just to go flat, and they have no regrets, and that I understand that's a new movement that's going on, and that's great too. But for me, it was about being made to feel whole again, and wanting to feel like myself again, and wanting to see that in the future I could feel that way again. I could look at myself in a mirror and look good in clothes, and feel like the woman that I am. And that was my personal decision, and I have no regrets. And I was very, very happy to get to know Dr. Paredes through that process, as we were together for a lot of months, and he walked me through it, and we made it.
Fantastic. And Dr. Syed, will you give us some insight into treating breast cancer with radiation therapy? Like, what exactly determines whether a breast cancer patient receives radiation therapy as part of their treatment?
Sure. So there are, of course, exceptions to every rule, but generally speaking, radiation therapy is the standard of care after lumpectomy. So all women who undergo lumpectomy should undergo radiation therapy adjuvantly. And in cases of mastectomy, we do our best to avoid radiation afterwards, but in women with larger tumors, so tumors bigger than about 5 centimeters in size, or women who have lymph nodes involved at the time of their diagnosis, those patients are often advised to undergo radiation therapy as well after surgery. Radiation therapy, the side effects tend to be fairly mild. We do our best to have radiation be as well tolerated and unobtrusive in women's lives as possible. Generally speaking, the common side effects that patients experience will be some fatigue, and then some skin redness and irritation in the areas that we treat. Generally, we deliver radiation just to the breast or to the chest wall. And in cases where women have involved lymph nodes, we'll treat those lymph node areas as well. But, the field is relatively contained to just the breast and a little bit of skin area around that.
And how has radiation therapy evolved over time?
Yeah, so there's been a lot of effort made to really sharpen the pencil and cut back on radiation where possible, while still achieving the same disease control and the same positive health outcomes. So now we have a few different treatment regimens, and the choice of regimen is specific to each individual patient, and each patient will have a conversation with his or her radiation oncologist to decide on the best course. But regimens now go from 5 consecutive days all the way up to about 6 weeks of daily radiation. And again, it's just the specifics of each case which determine which regimen is best. There have even been some studies looking at emitting radiation for older patients, for patients over the age of 70. Again, patients can discuss with their radiation oncologist whether that approach is appropriate or not.
Thank you. Before we switch into our next topic, I want to make sure I remind our viewers, if you have questions, please submit them in our Q&A portion, and we'll go over those and let our panelists weigh in on them. Of course, survivorship is the end goal for every person who receives a breast cancer diagnosis. Betsy, when you look at your own journey with breast cancer, was there a point where one day you said to yourself, I beat this thing, or is it just not that simple?
It isn't that simple. I mean, there's a lot of milestones that you celebrate along the way. The type of cancer that I had, however, has a discouraging recurrence rate compared to other cases. So even when I was done with my surgeries and I was done with my chemo and I'd rung the bell and everything, I knew that I had, a year or 2 or 3 where I had to be very vigilant. and I'd have to go to my doctor's appointments to get my blood test done and just be very vigilant because it could always maybe come back. Obviously, the hope is that it doesn't, but you have to be careful. And so that does something, I think, to your psyche a little bit, because you don't feel like you've really graduated, like it's really in your past. And so I think that's just maybe a common misconception about, you beat cancer, you're done with your treatment, and it really, truly, as you say, is not that simple.
Dr. Syed, what does survivorship look like from a medical perspective? As a physician, at what point do you consider someone in remission or cancer-free?
We know that there's always a risk of cancer recurring after definitive treatment, even in women who have no evidence of disease after their surgery, chemotherapy, and radiation. So we are very vigilant with patients after treatment. We'll typically recommend more frequent mammography in lumpectomy patients for the first few years. And it's very important that patients see a physician on a regular basis in the beginning, every 3 months or so, for physical exams. Typically, I like to follow patients for about 5 years after their definitive treatment. Observationally, we know that the risk of recurrence gradually falls over time. And at the 5-year mark, I feel relatively confident that those patients will remain disease-free and they can resume their normal breast screenings and follow up with primary care physicians.
And Dr. Blank and Dr. Silberman, with medical and technological advances, what does survivorship look like now compared to the past?
We've made a lot of advances in recent history, and so patients are living longer. We have more cures. We're diagnosing patients earlier, and because there are more cures, we're following them for a significant period of their lives. So we have to consider, what are we doing to the patients with our treatments, and be careful to follow, for example, their bone health or their gynecologic health and their emotional well-being. All those things really matter. So that's part of the follow-up process. When they come in for their my schedule, for example, in medical oncology would be a history and physical exam every 6 months for 5 years, and then annually after that. I follow many of my patients indefinitely. A lot of them do have extended endocrine therapy or the anti-estrogen therapies, which is part of the reason for that. But it's often also because of the survivorship issues as well. So trying to address them. And fortunately, we have a wonderful patient navigator system that Amy can talk about, where we're making sure that we're hitting all of the marks in terms of survivorship.
And sticking with Dr. Blank or Dr. Silberman, are more women surviving breast cancer today than even 20 or 30 years ago?
I think that I think there are some types of breast cancer that still present a real challenge, but I think the fact that we know which ones those are and can really tailor therapy and be more aggressive without over treating everyone, which I think we sometimes did in the distant past. So I do think that that we're making inroads into that. I think that, as Dr. Silberman said, also, survivorship looks very different because people are living much, much longer. And so I think we have to be forward thinking about what that looks like. That, 70 used to seem like an elderly age. And so we would maybe not give people the full complement of therapies. Whereas now we know that many people who live to be 70 or 80 are going to live another, decade or two. So those are differences. But I think the biggest thing from my standpoint is you were recognizing the differences in different types of breast cancer, being able to target therapy and try to achieve those better outcomes. But Dr. Silberman, I'll turn that to you.
That was great. No, the only thing I would add to that would be what she was touching on is that breast cancer comes in many different flavors. It isn't one disease. Biologically, it's very diverse. I mentioned before briefly the receptor status. So we look at hormone receptors, we look at HER2. What Betsy was talking about, her experience was triple negative breast cancer, which is the most aggressive breast cancer, and then HER2 positive, which is right underneath that. And then just within the hormone receptor positive HER2 negative breast cancers, that's a spectrum, right? So we've got people who are 100% estrogen and progesterone receptor positive, HER2 negative, the slowest growing, most indolent cancers there are. And then on the other end of that spectrum is they're 5% hormone receptor positive, HER2 negative. They behave very differently and the treatments are very different. So definitely not one size fits all.
Before we move into our questions, thank you so much, Dr. Silberman. Amy, would you please tell us about some additional resources TMH has for regular proactive breast health care outside of being diagnosed?
Yeah, so at TMH, we are very proud that we have our own mammography clinic. They do routine screening mammograms, and they also have follow-up if any abnormality is identified. We also offer genetic counseling and genetic testing. This is for patients with a new diagnosis, a past diagnosis, family history, where they can get help with like medical management, as well as gather information for themselves and for their relatives.
All right, wonderful. One of the questions that we received from a viewer follows, my question is for Betsy. Are you feeling like your pre-cancer self now?
Yes, but improved. So Betsy 2.0. Yes, and I think that's a great question, because when you are shocked with a diagnosis of cancer, it's like you want that old life back so much. It's like a defense mechanism. And the journey that I've had has not been easy, and it has not been fun, but it has led me to some very meaningful experiences, relationships with other survivors, my friends. It's given me an opportunity to help educate people about, especially younger women. I was 36 when I was diagnosed, and to encourage people not to be scared and just to go get checked out and to be vigilant. And so I think I am my old self, but I have a great purpose now added in to my old self. And so I'm just happy to be exactly where I'm at.
Betsy 2.0, I love it. This question is really for anyone. Is there a chance of reoccurrence after a mastectomy?
Yes. So I always tell everyone again, breast cancer is not a disease of always or nevers. And so breast cancer can behave in very sneaky ways. And so even after a mastectomy, where we remove, virtually all the breast tissue that's there, you can still have a recurrence, and that recurrence can manifest in different ways. So you can have what we call a local recurrence, which is a recurrence that, happens in the area where the original cancer was located. And that can be in the skin, it can be in the chest wall, it can be in, in that same area in the mastectomy flap. You can also have regional recurrences, which are recurrences in the lymph nodes that drain that area. So typically it's going to be under the arm or near the chest wall. Or you can have distant metastasis or recurrences, which is a recurrence that appears far away, somewhere else in the body. And so we treat those in very different ways, and they each have very different prognoses. But yes, even many years down the road, unfortunately, there are some tumors that will sort of lay dormant and then pick just the wrong opportunity or right opportunity if you're a cancer cell to rear its head. So that's sort of, and Dr. Silberman, you can add to that if you'd like.
No, I agree with everything you said. I don't really have anything specific to add.
Okay, and something else that we can talk about, maybe Amy or Betsy can chime in for this. Talk a little bit about the family and what it's like to have to not only explain to your family what is happening, but what their role becomes in trying to support and being there for you. Really, anyone could weigh in, but just talking about having those conversations, whether it's with parents or small children, spouses, or just needing that support and what it looks like for the family to go through this with you as well.
Well, I can speak to the children part of your question. My daughter was 6 and my twin boys were 4 when I was diagnosed. And that is a difficult age to explain what was about to happen. I was very worried that I would not be around as they got older. So I wanted to explain to them as honestly as possible in an age appropriate way what was happening. And so people gave me books. I got a book that says "Mom Has Cancer!" And that was the title of the book, which is kind of a funny title, I thought, but it was actually a really good book to sit there and talk through the process with them. But I wanted them to be prepared when mom comes home and mom is tired and mom's hair starts to fall out and mom's not going to have hair for a while because I'm taking this medicine for my breast cancer. And then when the medicine's over, then the hair will grow back and everything's going to go back to the way it was. And that's kind of the conversation I had with them. I was diagnosed shortly before Breast Cancer Month, so they were hearing all about it in school just as I had been diagnosed. And I think that was helpful because they were able to see this is something that happens to people. This is not an uncommon thing that's just happening to our mom, and gave them some comfort in the community as well. But those are difficult discussions to have. And I think you just have to parent the child you have and try to meet them where they are and explain it to them in a loving way, but a realistic way as well.
I'll just add to that and say we do have counseling services here at TMH Cancer Center that they will meet with the family, the spouse, the patient, the children, and try to help walk through the process and things that they're dealing with. A lot of times the control has been taken away from everybody, and it's not something the husband can fix or the wife can fix. And so sometimes talking it through with our counselors is very beneficial.
Thank you, Amy. Are there any significant dietary or exercise restrictions during cancer treatment or at different times during treatment?
I mean, from my standpoint, I would just say, kind of all things in moderation, making those healthy choices. As Dr. Paredes had talked about, if you have diabetes, making sure that you're, watching your diet and making sure that's well controlled. Eliminating nicotine use, smoking, vaping, moderating alcohol use, and really not gaining tons of weight during the process. But generally, it's just kind of healthy nutritional changes. There will be some exercise restrictions around the immediate time of surgery, but usually they don't last terribly long, and you can kind of get back to your regular regimen. And Dr. Silberman, I'll let you kind of address because I know chemotherapy changes things markedly.
It does. So during chemotherapy, I recommend that they stay as active as possible without exhausting themselves, right? So every couple hours, get up, walk around. When you feel like you have energy, take advantage of it. But when you're tired, to rest. I recommend, patients will ask me what sort of diet to eat. A healthy Mediterranean type diet, farm to table. If it's in a package you have to open, there's probably a lot of preservatives in it. So try to eat fresh foods, home cooked foods. Other things, once they're past the chemotherapy part of it, I'm very adamant, and my patients will tell you, I bug them every time they come in. I want all of them exercising. Ideally 5 days, if not 6 days a week, and getting your heart rate up and breaking a sweat. So regular vigorous exercise in survivorship has been shown to reduce the risk of recurrence. That's actually objective data that we know now. And as Dr. Blank mentioned before, it also helps with your cardiovascular health and your bone health, keeps your weight down, your blood pressure down. So it's really a win-win. People sleep better at night. Their emotional health is better. They have less mood swings, less anxiety. So there's no reason to neglect that aspect. Most of my patients actually will have, I'm not proprietary, so I don't say specifically a Fitbit, but some sort of exercise tracker, smartwatch where they're keeping track of their steps and their heart rate. And that way they have a goal and they know if they've achieved it. And if they haven't, they know what they have to do to get there.
And Dr. Silberman, sticking with you, this question was sent in. How important is mental health care after a breast cancer diagnosis and during treatment?
Well, you can imagine that it's just enormous for the patient and the patient's family, whether it be minor children, adult children, extended family. So it's something that needs to be addressed often, repeatedly. We take a review of systems. We talk to our patients about what they're experiencing. We address their anxiety, their depression, and sometimes we do it with therapy. Sometimes it's pharmacologic. Sometimes it's with exercise. So, you need to be looking at the whole person. And I'm sure that Betsy can talk on this point, and it would be even more relevant and poignant than what I'm saying.
Oh, I can always talk on any subject, Jeannine, but you're absolutely right. What you're going through is so multifaceted at that point in your life. And I always tell people to listen to their body and listen to their minds. And if they need help, if they need counseling, there are resources out there. If it's talking to a friend that makes you feel better, if not talking about it is what you need to do, then that's okay too. I went through a period where I didn't want to talk about it at all. And then as I got a little bit further along my journey, I did want to start opening up. And now as a survivor, I will talk with anybody who's been diagnosed with breast cancer about all of the aspects of my treatment. That's therapy for me, because I feel like that knowledge is going somewhere and doing something for somebody. So I just encourage people that I speak to, listen to yourself, listen to your body, find a counselor. There are resources, I'm sure, through TMH that can provide that essential service, but to take care of yourself, because this is a long, long path and it's not over. Like we discussed earlier, just when you finish treatment, that mental burden of being a cancer survivor and knowing the possibility of recurrence is out there stays with you, and you need to address it, and I need to address it personally, and I do. But that process doesn't end when the surgery is over and the cancer's gone.
Another question that was submitted says, how much interaction is there with your surgeon after completion of the surgery, and who do they turn you over to that will manage your treatment?
So everyone's a little bit different in terms of who they follow up and how frequently and for how long. Typically, patients will continue to see me on at least a somewhat regular basis for at least 5 years, and sometimes into perpetuity. As Dr. Silberman says, there are patients who either their primary would prefer them to follow up with their surgeon just for their clinical exam, or they have a risk profile that we need to do screening that's a little bit different in our kind of high risk surveillance program. So there's a lot of variability, but generally you're going to, those visits are going to kind of stretch out after surgery. So around the time of surgery, you're seeing us pretty frequently. And then once you're through that, then normally the first 2 years, it's about every 6 months. We stagger that with the medical oncologist and the radiation oncologist, so that someone is checking you usually about every 3 months. And then after that first couple of years, then we stretch it out to yearly. Again, they're still seeing you too, so you're still seeing someone with some frequency. And then at 5 years, depending on what those other risk factors are, we'll offer you to continue to see us versus following up with your primary doctor, your gynecologist.
Thank you. Is there anything women can do to lower their risk for lymphedema?
So the risk of lymphedema is highly variable depending on what what stage of cancer and what therapies you receive for your cancer. So for folks who don't have any axillary involvement, who undergo only a sentinel lymph node biopsy and don't need axillary radiation, the risk of lymphedema is very, very low. It's not zero, but it's quite low. For people who have axillary lymph node involvement and are going to require more aggressive surgery in the axilla and or the addition of radiation, that risk of lymphedema, which is arm swelling, arm heaviness, potentially weakness, that risk goes way up. So for those people, we try to be proactive and have them be seen by lymphedema therapists prior to their treatment so that we can prevent it rather than treat it on the back end. So if we or whoever you're seeing aren't thinking of that or don't do that, you can always, that's always something to have a discussion about and see if it's worthwhile to go ahead and proactively see the lymphedema therapist on the front side to do some of the massage, sleeves, all of the things that will help prevent the development of lymphedema.
And we have two questions about breast pain. One is not so much a question, but a comment that we received that says, I'm just 1 year out from chemo and radiation, just had my mammogram and blood work, but still worry every time I feel pain in my breast.
So from my standpoint, it is far, far more common to, whether you've had breast cancer or not, whether you've had breast surgery or not, breast pain is super, super common. And I never say never, but it is rare that is the presenting symptom of a recurrence. So I would say that, for every 100 people that I see with breast pain, maybe one has a concomitant breast cancer, and that's probably even a conservative number. So there are, it's, you want to be vigilant, and it's normal to kind of feel that anxiety and a little bit of worry when you go for your mammogram or when you feel something or something seems different. But I would say don't suffer with the anxiety. Reach out to your provider, whether it's your oncologist or your surgeon, and go in and have them check it out. Because it may be very easy to allay that anxiety and that fear. But I would say feeling pain after surgery, even even a year and a half out, can be very common. And some people have breast pain even who've never had surgery, and it's rarely associated with a cancer.
Another person asked, after 5 years, when you're turned back over to your primary care physician, what labs or diagnostic studies should be ordered on a yearly or biannual basis?
I can tackle that one. So there really aren't, for patients who are treated for cure, so they're stage 1 through 3, they don't have metastatic disease or stage 4 disease, there really aren't good tumor markers to screen for recurrence. So the most reliable use of the tumor markers, which is a blood test, is in metastatic disease to the bone specifically. So really, for those folks that are discharged and go back to their primary care, for the most part, what I'm recommending is history and physical exam once a year, starting year 6. If they have still breast tissue, then annual mammogram. If they're high risk, more frequent than once a year. Sometimes we'll alternate between MRI and mammogram, but typically those high risk patients will continue to follow with us. Anything else you would add to that, Dr. Blank?
The only thing, and I'll let Dr. Paredes kind of address any of the new surveillance regarding people who've had reconstruction. So if you still have, if you've had a lumpectomy, you still have breast tissue, you still want imaging, whether it's MRI, mammogram, or a combination. If you've had mastectomies, there is some role for MRI, not so much to look for breast cancer, but to evaluate any, if you have autologous reconstruction. And Dr. Perez, I'll let you address that.
Yes, that's a common question for us. And so if you've had, I tend to see more of the mastectomy patients. So if you've had a mastectomy, we're not doing mammograms anymore because there's nothing to x-ray. It's just basically skin, fat, and then your reconstruction. a lot of that's implant based, and so there's nothing to mammogram anymore. If a patient feels something, we'll usually go straight to ultrasound or MRI rather than a mammogram. It's quite common for me to see patients who get those reminders sent by their primary care office or by their GYN to get their yearly mammogram, but the computer doesn't realize that sends out the reminder that you've had a double mastectomy. So that's important to understand that. So when you've had reconstruction, I would go over as a patient with your doctor what imaging we recommend. For implant-based reconstructions, the FDA does recommend an MRI at about the 5th to 6th year after the placement and every 3 years thereafter. And that's just to check to make sure that the device is holding up and hasn't broken or something unusual. If a patient came to me with some type of pain in their breast that seemed unusual or in a certain spot, we would usually go to an MRI to look at that area, but there's not any specific imaging beyond what I mentioned about the implants and MRI.
Most of the time, even if you're 10 years out, however far you are from your surgery, if you call your surgeon, the first thing they're going to say is, come in, let's check it out, and then figure out what, if imaging needs to be a part of it, if it's, something that needs biopsy or what the best way to approach it is. But that 5 years is sort of, arbitrary based on risk and, how likely we are to find something. And as long as a patient's primary is doing, a yearly exam, but there's no time that you can't call your surgeon and come back in if there's something that you're concerned about.
Mm-hmm.
And
the only other thing I would add to that is that from my perspective, the follow-up is a clinical one. And by that, I mean, if you're not stage 3, in which case I'm typically doing a PET CT scan once a year for 5 years. And if you're not stage 4 and they're having more frequent imaging even than that, so I'm talking about stage 1 and stage 2, it's a clinical follow-up. So, history and physical exam twice a year for 5 years, and then annually after that. If they still have breast tissue, the mammograms. Beyond that, unless they have a specific complaint, I'm not doing imaging. So the imaging is driven by, I've got a pain here or a lump here, and then I'll order whatever needs to be done, an MRI or an ultrasound, whatever appropriate test there is.
Thank you. Amy, if someone has additional follow-up questions about their personal breast health or would like to ask questions, who can they contact?
I'll be happy to talk to them and answer any questions they have. They can go to the TMH website at tmh.org/breastcancer, or they can call me directly, 850-431-3433, or amy.anderson@tmh.org.
Thank you. We're coming to the end of our time, and this conversation has been absolutely phenomenal. I think the viewers who have tuned in have really been able to walk away with some incredible information. But in closing, we want to say, what is the most important message each of you want our viewers to walk away with from our talk today? We will start with Dr. Paredes.
First, I would say don't delay. Just like Betsy said, don't delay getting to your doctor if you're concerned about something that you feel in your breast, and make sure that you get your mammograms as you're supposed to. And regarding reconstruction, just some general advice is I do meet patients who feel pressure that they have to get reconstruction. That sometimes comes from their children or a neighbor. And I think it's well-intentioned people, but I think it's important to understand that reconstruction is an elective choice, and it's really up to the patient to decide if they want that. So you feel free to explain that to your plastic surgeon when you come to your first visit.
Thank you, Dr. Paredes. Dr. Silberman.
I absolutely want to echo, don't wait to seek medical attention. Unfortunately, we saw a lot of people that did that during the pandemic, and, with a variety of different outcomes. So please don't do that. Call your doctor if you have one. If you don't have a doctor, which is not an uncommon situation, call Amy. Amy can find us. We can figure out how to help you. No question is too silly to ask, really. I mean that. And consider your lifestyle. What lifestyle changes can I make that'll bring me to a healthier place?
Dr. Syed.
Yeah, just stress that cancer treatment, breast cancer treatment, is a team effort. All of us on the screen work very closely together to tailor the right treatment for each individual patient. Don't be overwhelmed. Ask questions of all of us. And when things pop up, any of us could direct you to the right resource or get an answer for you. So yeah, just come with questions and we're here to help.
Thank you. Amy?
I would say definitely have your mammogram and don't be afraid to ask questions. Like, I'm always available. There's lots of resources out. So make sure you utilize those resources and get some help if you need it.
Thank you. Dr. Blank?
I would echo what these guys have said. Most breast cancer is imminently treatable with a great treatment and a very good prognosis. But the ones that typically are not are ones that have been around a long, long time. So again, delaying is really counterproductive. Don't let other barriers, like whether they're financial or otherwise, kind of delay that, because there are plenty of resources. We're here to work with everyone. So please, if you get that help somewhere, whether it's TMH or close to where you live, there's someone there to help you.
Thank you. And Betsy, the topic of today, the title for this discussion is The Truth About Breast Cancer, a Survivor's Perspective. Betsy 2.0, give us your closing words as to what you want our viewers to take away after listening in tonight.
Sure. I would tell people to be aware, but don't be scared. I feel in my discussions with women that one of the reasons they do delay that mammogram, or they don't reschedule it when they miss it, and so on and so forth, is because they are scared about what could happen. And I'm here to tell you that those screening mechanisms are there to protect you, and there's nothing to be scared about. I was a very rare case, and the odds are still very good that your mammograms are going to be fine. And just think how much better you're going to feel when it's over and it's behind you. And so I feel discouraged when I see women delay that because they're scared. Don't be scared. You're going to be fine. It's going to be okay. No matter what it is, it's going to be okay.
Thank you. I want to thank each of you for taking your time out this evening to talk to everyone, as well as everyone that tuned in for tonight's insightful discussion. If you're interested in learning more about breast cancer, the incredible care offered at TMH, and more ways to raise awareness during Breast Cancer Awareness Month and year-round, you can visit tmh.org/go pink. We hope you all have a great rest of your evening. Stay healthy, and women over 40, don't forget your annual mammograms. Have a great evening, everyone.